Okay, so welcome everyone. So today is the concluding lecture of our lecture series, and we have started this lecture series last year, and today is the 12th lecture, which is the concluding lecture from Dr. Manju Rahi today. And in the series, when we started, we never imagined that we would be able to connect with so many people throughout India. And we started with the keynote lecture from Professor Edwin Hill, who talked on the new vaccines for malaria prevention. Then Gyanu from Johns Hopkins, mycobacteria, Manu Prakash on frugal science, Aaron Dondrop for multidrug resistance falciparum malaria, Dr. Shyam Sundar on visceral leishmaniasis, Shashank Tripathi from IASC COVID-19, Dr. Regina Rabinovich on malaria control, Tapate Sethi from IIIT Delhi on artificial intelligence, Dr. Anuradha Chaudhary on multi-drug resistance in fungal pathogens, and the last lecture we attended was from Dr. Saman Habib on interventional strategies on malaria parasite. So today is the 12th lecture, as I said, and we are thankful that we have Dr. Manju Rahi with us. Dr. Rahi, before she start, I would give a brief introduction of her. Dr. Rahi is a scientist F and Deputy Director General at the Division of Epidemiology and Communicable Disease at ICMR Headquarters, Delhi. She did her MD in Community Medicine and postgraduate diploma in Epidemiology from Government Medical College, Maharashtra, and Public Health Foundation of India, respectively. She joined ICMR in 2006 in the Division of Nutrition because of her interest in research. She later shifted to infectious disease. She has been handling the research programs on vector-borne disease and One Health since more than a decade now. Having a deep interest in public health policies issues, Dr. Rahi views culmination of research programmatic efforts towards public health good as the ultimate aim. She has contributed and led research in some of the first policy pieces like guidelines on probiotics in India, guidelines of diagnosis and management of bacterial infection, additional of third drug ivermectin to chemotherapy of lymphatic filariasis, addition of DEC salt to public health policy of LF chemotherapy is underway, pioneering work on Wolbachia containing Aedes mosquitoes for control of dengue, WHO guidelines on sterile insect techniques for control of dengue, and developing target product profile for Wolbachia technology in Aedes mosquito. So this is a short introduction of Dr. Rahi, and with this, I would also like to mention here that she is the officer in charge for MERA-India program also at ICMR headquarters, and she has been very supportive and provides her guidance throughout the program. In fact, in each and every idea behind she has and Dr. Amit Sharma, Director NMR, has contributed a lot, very enthusiastically from the beginning of this program inception, and she is associated with the program from its inception when this program was started in 2019. So without any further delay, I request Dr. Rahi to start the presentation. She will take us through the malaria journey in India today. Dr. Rahi,
yes,
you please start.
Thank you, Sachin, for lovely words. But it's my privilege and honor to be here, and I thank Dr. Amit Sharma, Director, for inviting me for this talk. And I actually feel really privileged and humbled because all the past speakers have been the luminaries in their field, and I feel this is little. I feel humbled in their presence, and they are some of them have been my teachers, and they are the stars in their field. And it's an honor to be here on this platform. So today I'll just today the topic has been to strategies and tools to maintain the momentum. Share the last one. Strategies and tools to maintain the momentum of malaria elimination in India. So today, as Sachin said, this is the last lecture of the series, and I think it's very befitting to talk about the malaria elimination journey of our country, India. And we have been able to achieve a decline in the malaria incidence in the country, and it's always apt to maintain that momentum But yes, with the current strategies and tools, it would be possible to eliminate malaria in the time, but the 2030 deadline is there. How do we maintain the momentum? How do we overcome the roadblocks and the speed breakers in our journey? I think is an issue of discussion and debate. So here we have passed over 2 and 3 years with NMR, with Dr. Amit Sharma. A lot of brainstorming with the scientists have happened, and we have come to deduce what could be the possible roadblocks in this malaria elimination in the entire process. And 2027 is the time where we have to achieve the last elimination of the last case. And because this is a case-based, last case has to be eliminated, unlike Kala Azar or lymphatic filariasis, where the targets are, they are like less than 1 per 10,000 at the block level. But in malaria, the target is 0 case. So that's quite a ambitious target. And us from research side, definitely elimination is the responsibility of the national program and the Ministry of Health and Family Welfare. But from the research side, we can contribute our best to finding what are the barriers, and then how do we overcome these. So what I'm going to present today is the kind of a journey of elimination and where can be possible problems and how do we overcome this. Definitely new tools, new strategies might be needed, or the existing tools might be used with more, re-energized vigor. So that's all, and we need to be flexible in our policies for policy makers and decision makers. We need to shed off the inertia, which sometimes happens in a very old and established programs in the country. And we have example of polio and smallpox eradication where India has done exceedingly well. So I begin with this map where ICMR's institutes are shown as spread out in the country. These are 8 or 9 institutes which work on vector-borne infections, specifically on malaria, and the field stations which are spread across the country. So we have a footprint across, and there's a very close collaboration with the state governments. These institute scientists work in the communities. They work in the field for different kinds of studies, ranging from basic sciences to operational and implementation research. So the footprint is wide. You can see from northeast to the South India, to the northern part of India, to the western. So all these are basically, most of them are malaria endemic regions, or they are close to them. Our institutes are working in this region for past many decades now. India has a long history with malaria, and it's an ancient disease, and we have been fighting it from past so many decades. It has been called as king of diseases. There is this particular paper by Dr. V.P. Sharma, who's the founder director of the institute I'm sitting in here. And so I was just reading through multiple papers, and this is the history of malaria in short for India. Most of us are aware of this history, but it's always good to revisit where were the problems and how do we not see the problems again in this new modern era with the tools which we had, which unfortunately were not there with us in 1950s or 60s or even 70s for that matter. So that's how the history flows for India. It was called as king of diseases. There was a lot of economical losses, and with DDT showing exemplary results. India thought for a national malaria control program in 1953. The results were so good of DDT that the India government changed it to eradication program in 1958. There's a remark in Dr. V.P. Sharma's paper which I found as it's very amusing because it's kind of satirical. It says that DDT eliminated expertise from the country. It eliminated malaria expertise because we relied heavily on DDT as a vector control tool. So DDT was wiping off the mosquitoes and wiping off malaria. So and so that 1961 was the landmark year where the lowest number of cases of malaria were seen. There was economic growth, there was industrial growth, green revolution, everything happened. And I think this is, even now in 2022, we will not be able to achieve this less a number. So that was history made. But again, as I said, Sharma sir said that DDT was the one where we forgot everything else. And we got busy in smallpox eradication program. There was divergence of resources. There were so many other factors which took our attention away from malaria, and we could see a resurgence in 1976. 6.45 million cases was not a small number to tackle. The entire workforce was disheartened by this backlash of malaria cases. We were back to control strategy in 1977. Swedish International Development Agency supported a falciparum containment program because till now Vivax was the predominant strain. but slowly falciparum became, was encroaching in more and more areas. 1980s, the malaria outbreaks continued. 1982, the first drug policy was instituted, where there was a discussion on chloroquine, which area should be getting chloroquine, and I'll show the drug policy changes in another slide. So these were changes which were happening. But 1984 to 1998 was still, the incidence hovered around 2 to 3 million cases annually. 2002, integration of malaria control program happened in NBDCP, where under the umbrella program of the National Vector-Borne Disease Control Program, malaria was included along with Kala-Azar, lymphatic filariasis, dengue, chikungunya, 6 of them. And further horizontalization of the national program happened when National Health Mission was constituted in 2005, where it was from absolutely vertical, it became that it has to be done via the national health services, the primary health care of the country. So that's why horizontalization has come up to, and it has its own disadvantages as well as advantages. We all of us understand from that point of view. When a program is vertical, it has special attention, special budget, a lot of resources are diverted towards vertical programs. When it becomes horizontal, the staff is not very specific for the program. It has many other duties, it gets diluted. So there has to be a very fine balance between the pros and cons of vertical as well as horizontal programs. Anyway, so the milestones were 2005 was a landmark year again, where the rapid diagnostic kit was made available, even though it was monovalent for falciparum initially. And then ACT was introduced in chloroquine resistant area in 2006. 2009, L-Align came, which became a magic wand. I think ACT, L-Align, and RDT were the magic wands for malaria control. The decline was sharp after these tools were introduced. 2010, revised drug policy and ACT in all falciparum cases, because falciparum chloroquine resistance was rampant. 2013 was another good year where bivalent RDT was introduced, and Vivax and falciparum both could be detected in the field by a lay healthcare worker who could be trained minimally, and you could do the detection in the field itself, and the treatment could be given at that particular point. Then there was a policy change in the drug policy change. ACT, artemether lumefantrine, was given in northeastern states because of, again, drug resistance in the northeastern states to ASSP. The rest of the country continued with ASSP even till now. 2019, aligning with the WHO's call for elimination, global technical strategies was launched. Side by side in India, launch of elimination plan through National Framework of Malaria Elimination 2030 happened. 2017 was the operational manual for how to do this elimination, what are the activities, called as National Strategic Plan for 5 years was launched. And now another 5 years National Strategic Plan is due, which is being made in the ministry. 2022, just last month, we have wrapped up the malaria program review jointly done by NCVBDC. Now the name has changed of the national program, and by WHO, where 6 states were field visits were made, and the lacunae in the field were found out, and a good review of the malaria program has been done. So not taking much time on the history of it. So this is the history of the drug policy changes, how it has happened over the years. And this particular chart is already published in one of our papers, and this is available otherwise as well. So there were many landmark years where the policies of the drugs have been changed. So this is the incidence which I'm showing from, again, Dr. B.P. Sharma's paper from 1960 to 2010, where you can see the longer dark green color bars are the total incidence of malaria, where the peaking of cases in 1976, where the highest number of cases, 6.5 million, were seen. And then there is a downfall in the cases. And the red bars are the falciparum, because chloroquine was not sensitive for the falciparum species. The red bar are more or less consistent over the years, because falciparum was not coming down. It was the downfall of Vivax which brought in the downfall in cases. This was till 2010. Excuse me. From 2014, if we see the graph, till 2021. So these are the bars for yellow one is the falciparum. Now it has become the predominant strain, and green one is the Vivax. So again, there is a downfall in the cases. 2016, elimination plans were launched. And after that, if we see after 2016, there is a sustained decline in the number of cases and number of deaths. So there are, I mean, majority now, 2021, there were around 150,000 cases, overall cases, and majority around 99 or 1 lakh cases are falciparum. And if you see the death graph also is very less. Because of COVID, there must be some disruption in the surveillance, but more or less it's on track as far as we are concerned up till now. Malaria elimination for India is on track. And if we keep the momentum, there is all likely a chance that we will achieve elimination on time or around that time. So this slide I have generously borrowed from Dr. Amit Sharma's one of the presentations, where 2020 data and 2021 data are being compared. This is the state level data where the dark red portions are where annual parasite incidence of malaria is more than 2 and 1 to 2. So we can see the red areas, which are the problematic areas where there's still high burden, which is around Chhattisgarh. Some of it is Odisha Southern District and Gadchiroli area of Maharashtra. So this is 2020. 2021, we can see again, so similar districts are the problematic districts of India. And of course, much more attention is being paid to these areas. So if we see more granular data, that was the state level. If we see more granular data from the district level point of view, and this data was shared with us by the national program, we are thankful to them. So this is the district level data of 2020. So these are if you can see the dark blue patch, Telangana, some of the districts, and Chhattisgarh, Odisha. So this patch is the area where the API is still more than 2. And if we go more granular, this is district level. The moment we go to blocks and to PHCs and to villages, we can further analyze which are the area where there is persistence of malaria, and maybe despite all the best of tools being used, malaria is not coming down. We need to do an investigation there. But this is the overall picture, and this is actually a beautiful success what India has achieved in this past 30, 40 years of starting from resurgence in 1976 to this 20 years now. So as there is a tailored approach from the national program where different categories of the state are given different treatment as far as program is concerned, whether it is surveillance strategies or vector control strategies. Diagnosis and management and ICBCC are more or less similar, but in the intensified control phase in category 3 areas, it's more intense ICBCC. But yes, if we can appreciate the major differences in the surveillance of the two type of areas, which are pre-elimination or near elimination, and where we are still struggling with a high API. So this is from the National Strategic Plan. Now coming to the crux of today's talk, and why we are talking about elimination if everything is going hunky-dory, we are all good, we are on track. So far, so good. But what we envisage is we continue in this particular fashion. Yes, it is very good, but all of us are aware how last mile challenges can be very tough, and still we haven't reached that last mile. As per India's own calculation, there are still 150,000 cases. As per WHO's estimate, we are somewhere around still 4 million cases. So still it's a tough journey to go on, and there would be multiple challenges. And these two slides have just summarized what could be the possible challenges. And these challenges we have thoroughly brainstormed in NMR with scientists, with other malaria workers, malaria researchers across the country in many different meetings of even MERA-India. So these are the crux of where we should be paying attention as a country, not only as program, but also as researchers. So the first challenge is the inadequate surveillance. Despite everything is fine, we are into active case detection, passive case detection, all kinds of surveillance strategies are there, but just 1 second. But we understand even now currently the system of surveillance in India is paper-based. The healthcare worker will go to the field, she will collect the data, enter into the forms, and that data would be from the village or a PHC, which will go to a block to district through paper, and that district will communicate to the state will communicate to the center. That's how the flow of information is. It's still paper-based. There is no absolute use of technology at the moment. It's not in near real time also. It's monthly, which the program sitting in the center visualizes the data at a monthly basis, not at weekly or even sooner than that. And even if it's happened monthly, it would be good. But sometimes there is a lag of 2 to 3 months. So imagine the kind of information we are losing there on everyday basis. We are not able to see the surge in cases and outbreaks at a lower level. And so there is lack of real-time reporting and data visualization. The surveillance, the actual collection of data is paper-based. The data collation and transformation of information also is paper-based. So there are no alert systems here. The current malaria indices are still based on API structures. We should be moving on to more sensitive indicators is another need. Private sector at the moment is missing. It has become a mandated disease. It is a now notifiable disease in 31 states of India. So when I say notifiable, it means it is mandatory by law for the private sector to report the data, but it's not being currently done. We are in a talk how to rope in the private sector. And is it only for data collection we need them, or we need them as the major stakeholder in the healthcare of India? All of us are aware how in India, people's healthcare is mostly taken by private sector. 60 to 70%, or even the 75% of OPD care and 80% of IPD care is done by private sector. This is where the patient is going, but we are not taking those numbers in account. So febrile illness is majorly looked by the private sector, but they are not being taken into account so far. There are plans, we have to take them into our fold. The routine diagnostic tools are missing the asymptomatic patients and the subpatent malaria, which is not being picked up by microscopy or by RDTs, and the mixed infection by ovale and malaria, and the non-PF, non-PV like novel SAI, all these species are being missed. There are vulnerable groups like pregnant women, migrant workers, laborers, people who are uprooted after natural disasters. Those people are not included anywhere. They are orphans of the state and not recorded. Cross-border surveillance is another major area. It's a caveat for the international borders. This has been highlighted multiple times. WHO did some efforts in the past, but sharing of data, sharing of real-time data of cases and vectors is not happening till now. Then there is incomplete resolution of vivax. All of us understand vivax will become a very major hurdle for India's elimination plans. And in 2019, almost 50% cases were vivax, 36% in 2020. There were latent hypnozoids is the issue for with vivax, where they can flare up after any febrile illness or even initial infection by falciparum, which can trigger the vivax hypnozoids, and there you land up in falciparum as well as in vivax infection. It has been shown through studies, typhoid infection can trigger latent hypnozoids, so on and so forth. And there is a poor compliance to 14-day long treatment especially in the rural areas. Then there are issues with the microscopy and RDT. As I said, they are not sensitive tools. We need better tools than these two, maybe more sensitive PCR tools or molecular tools. Then there are deletions of HRP2 and 3. If they become more rampant in their prevalence, RDTs will miss the falciparum infection and they will miss diagnosing them. The threat of drug resistance is very well known to this August gathering. We are aware that, the drug treatment was changed in the Northeast from ASSP to AN in the face of resistance. So same threat is still there for the rest of the country. Currently, ASSP is working, but I'll show how the mutations are happening across the country, and we should keep a very tight vigil over it. Then there are indications for drug resistance. Vector control and vector dynamics is another challenge. Insecticide resistance to the synthetic pyrethroids being used. DDT has to be phased out slowly because of environmental pollution. We don't have much choices in the insecticides. Besides synthetic pyrethroids, there are new insecticides which are being used in the lines. Chlorphenrapyr, that trial is out. It's published. Newer lines, next generation lines are being developed and being tested. But still, we need to be more open to adopt these newer tools. PBO nets, they are there. Outdoor transmission. I don't know how far this is going to have implications on the current vector control tools like LLine and IRS, which are mostly indoor. So outdoor transmission, if that is a huge quantity contribution in malaria transmission, we will not be able to control it with the existing tools. Still, we have good tools for outdoor biting. So there is a behavior change that is being hypothesized that with long years of usage of LLine and IRS, vector is shifting to outside. It's biting early, it's biting outdoor. Are we ready for that change? Do we have the tools? We don't know yet. An incursion of malaria vectors in new areas, Anopheles culiciphasis has invaded Northeast. And many of these new vectors will, as we are getting into the forested areas, we are wiping them out. Culissifaces basically is a plains vector. So that's how we are getting this new area. Stephen C. Sri Lanka, that's how it is. And multiple stakeholder partnerships are very important. We need all the partners to work together. A lot of crosstalk is needed. So these are the challenges where we need to work on. And over the past 2 years, we have worked a lot on these challenges. We have written a few policy pieces where we should take a wake-up call and maybe think about these changes in the policy. If not now, maybe after some time, but we need to break those inertia, and the policy makers and the decision makers in the ministry, we need to at least have a brainstorming session and a discussion and debate on these topics. These are some of the papers which have been published in past 2.5 years. And the latest paper, which is accepted in Lancet Regional Health Southeast Asia, is culmination, is the summary of all these papers which have just happened. So I'll just quickly go through it because we have already spoken about them. So this is the need for an integrated platform of all these stakeholders, private or government or non-government, and besides the ministry, there are other government organizations. They should come at one platform where all the data is being reported, all kind of data, not only the malaria surveillance, but supply chain, entomology, vector data. All these data need to be at one single dashboard. And taking this vision forward, Dr. Amit Sharma and the scientist, Dr. C.P. Yadav, a very bright young scientist and a statistician, they developed this dashboard, which I think is a breakthrough. And this is a very, the national program shared 20 years data, and this is a very beautiful dashboard which has come up, easy to use, in our package. Dr. Yadav has more details. So you can just go on clicking and seeing how the data can flow through districts, and all kind of malariametric data can be seen. API, SBR, SPR, everything is available on this dashboard. This has been shown to the national program, and their discussions are on. These dashboards can be used for deeper analysis of the data, and researchers can use this for their own analysis. This is freely available. This will be made freely available by NMRT. So this is a fever app which was developed in collaboration with the Northeast Space Application Center, NMR, and RMRC Dibrugarh, another ICMR institute in the Northeast. So this is a data collection tool by the healthcare workers, and even the communities can use to self-report how Arogya Setu was made for COVID. So I understand many of the apps are available. There was an app made by Malaria Elimination Demonstration Project in Mandla that was called SOCH. So apps is just one of the way of data collection. Program should be actually able to use these apps, and they should teach or train their healthcare workers again. So another tool is a simple malaria card, which is, again, we understand it will be difficult for the healthcare workers to switch to the digital platform so soon. So this is a simple paper-based tool where the healthcare worker can fill in the information for the patient, and patient can keep this as patients keep immunization card of their children. This card can be kept, and this card has information not only of malaria, but malaria multiple episodes, the treatment they have taken, if they suffer from any hemoglobinopathy or enzyme disorder like G6PD. Similar cards have been used with a lot of success in Daman program in Odisha. In Chhattisgarh, this kind of card is used. So this is another card where people can take QA, and this is a very simple booklet kind of a card. So this also was brainstormed, and this paper has been published. So maybe this is kind of a record-keeping tool for the communities as well as for the healthcare worker. So another idea which we thought was, as Kala Azar, the visceral leishmaniasis and lymphatic filariasis also are in elimination phase, as well as malaria is, there is a lot of sense and logic in combining the three diseases, not only for the surveillance because the workers are common, but even the elimination program in all facets can be integrated, can be joined. There are a lot of areas where there's a lot of overlapping of the disease. 197 districts. India is a huge country which has 2 overlapping diseases. 25 districts, the red ones we can see here, where there are 3 diseases. So it makes a lot of sense to combine the resources, make use of the entry of the healthcare worker in the community for once and for all, collect the information, give the treatment, give the diagnostics. Everything is field-based right now. So it's a lot of resource saving here. So and that's what the platform shows, not only for surveillance, for diagnosis, management, vector management, community, and so on and so forth. We understand how Vivax can be a problematic. I already showed for Primaquine, there is a lot of, the compliance is poor. So the answer is yes, tefenaquine, which is a single-day treatment, one treatment by tefenaquine, and the person is done for Vivax. It's a long-acting drug. I understand G6PD is another hurdle, but this drug is coming with a companion testing, quantitative as well as qualitative testing for G6PD enzyme deficiency. So currently this is under regulatory consideration in India, but I still urge our ministry and the regulatory body, the DCGI in India, to consider it favorably. It has proven across the world it's a safe drug. Countries are using it. India can use that data, and we can go up to a feasibility trial, or we can go for a phase 3 trial, but we should skip the unnecessary steps and try to adopt this drug along with the companion diagnostic, which can be the healthcare worker can be easily trained in. So, and as I said, there are multiple partners for malaria elimination. The private sector is a major partner. So this paper is recently accepted, where we say it's not only for surveillance, but for multiple facets of malaria elimination. They need to be trained. What are the guidelines for malaria? How to run RDTs? So private sector, and there is a huge informal, unqualified private sector. We are not legitimizing them, but they exist. We can't ignore them. So you better train them, as we are doing in TB, in tuberculosis. They have been taken into the fold and they are reporting TB cases. Similarly, we can be more flexible and request private sector to join hands, and not only to report, but to join hands totally with the program for malaria elimination. So taking one step ahead from the private sector, it's not only they should be partner in giving the healthcare also for the malaria patient. So we are advocating the availability of rapid diagnostic over the counter. People can just go and purchase a rapid diagnostic, see if they are positive, and they can report to the health authorities for treatment. For COVID, how we have made available the antigen test over the counter. And there was a big hue and cry before that. No, our communities are irresponsible. They will not tell about the cases. They will not report. They will not be able to perform the RDT. Nothing. How COVID has changed people's mindset. I think it's time we can think about making the RDT available over the counter. Countries have done it, so can India. And we require more sensitive tools for diagnosis of sub-patent and asymptomatic malaria. TrueNat is one of the kind of point of collection, point of care diagnostic tool which can be easily used. We are doing a study on the feasibility of using a molecular tool in the field. Results will be available soon. So this has been already published that we would like to go ahead and one step ahead in using sensitive tools for the country, especially where areas where there is persistent malaria or the malaria is not coming down. I mean, all of you are much more well aware in the science behind it, how the sensitivity threshold is much more for PCR tools than RDT, and microscopy is played with the limitation of expertise. So this is how the comparison goes for the 3 diagnostics. And this is a map where in India, the diagnostic laboratories are available throughout and overlapping with the API map. So maybe where the API is high, we need to have more sensitive tools. COVID labs, which are using molecular tools like PCR, TrueNat, CBNat, they can be roped in, and these can be made easily available, at least at the district level, if not lower. So that we understand the threat of emergence of drug resistance. And that's how this is the map where quadruple, quintuple, sextuple mutations have been observed against SP. And I have been told that sextuple mutations are the highest level of resistance. It's an indicator of highest level of resistance. So these also are seen in a couple of places. We should be keeping a high vigil, but we advocate when in the Northeast there is a change in the policy to artemethyl lumefantrine. It should be done for the entire country because there are indications of ASSP mutation, especially for SP. So if the partner drug is not working, the entire thrust is upon artesunate, the artemisinin, the drug, and maybe it is acting as a monotherapy. We don't want to give it a short lease of life, so that should be given a full chance till artemisinin is effective. We should be able to achieve elimination and not make artemisinin redundant by having a redundant partner drug. So it makes a lot of sense if we can have a uniform policy across the country. Government of India can think about it. So vector control is another big challenge, and I'm very fascinated by vectors and the vector control aspect of malaria. So we advocate like LL lines can be made easily available to communities who can afford an LL line to just go and buy it from a shop. That's called social marketing. It can be easily done. There are a couple of studies. There's one study in Odisha where the voucher system was used, and it was seen that communities want to purchase L-Alliance if they can afford it, and with some subsidies, they can easily do it. This will cover a lot of deficits in the coverage, and people want to have extra L-Alliance in the house, so that can take care of it. And this will also free up the government resources. So we should think of loosening our mindset. Everything has to be given for free to people is fine, but people who want to have it can have it. So we are talking about novel vector control tools now. I'm talking about ivermectin. Trials have been done in Africa, in Burkina Faso, in Kenya, even in Vietnam. So where ivermectin as an insecticide can be used in humans as well as cattle, and mosquito will feed on these two hosts and will die. So this is an indirect method of vector control, giving this drug to people and to cattle so that mosquito dies away. So that's another way which is being tested, and I think India should test. NMR has done very initial studies on the susceptibility of vectors to ivermectin. So that will be published very soon. I think it's a way forward for vector control. So this is just example of how it is done. So when I was talking about outdoor transmission, where the routinely used L-Line and IRS will not work, maybe ATSB, attractive toxic sugar baits, are being used across countries. Israel has done a lot of experiments. So these can be tested, and there was some laboratory study done by Gaurav and his team in NMR for testing in the laboratory evaluation, and we are also framing guidelines on testing ATSB as a vector control tool for regulatory approvals as well. That also is in process and which will come up. India should be opening up to newer vector control tools, and these control tools can be used in forested areas, in tribal places where people are maybe migratory or they move along. So these bait stations can be used in those areas. And coming to my last point, and I know I've overshooted the time. So this is a beautiful platform. 2019, this was incepted, as Sachin informed all of us. Malaria Elimination Research Alliance. So from research side, we wholeheartedly support the efforts of Ministry of Health and Family Welfare towards malaria elimination. And we have funded some very crucial research studies in the first phase. So this is where the applicants were formed, and these were the thematic areas. This is the second call for proposals. Again, the thematic areas were brainstormed very, very sincerely and very seriously, and these were initiated. Young malaria researcher theme also was floated. People have applied in huge numbers. Results are being announced very soon. And besides the funding the research part, so there's a lot of advocacy in form of these lecture, distinguished lecture, which is a beautiful initiative from MERA-India. Workshops are happening with the investigators of the studies, and trainings are happening. There's a monthly newsletter. So I think congratulations to Sachin and his team. A lot of activities going on from this platform to support malaria elimination, and my all the best to this platform. And I think that's the end of my talk. It's a lot of packaging in one single talk, but I hope this is the public health perspective which I've been able to impart. And this is nothing new in this entire talk. All of us are aware what do we need sometimes, but push at the policymaker level where we need the political will to change or to add new tools and new strategies, I think will take us to the last goal. I end here, and I'll be very happy to take the questions or any query from the audience. And thank you, Sachin, and thanks NMR for inviting me here.
Thank you, Dr. Rahi, for the wonderful journey you have taken through us for malaria, particularly in India. So I have not very, lots of questions, but a few questions, if you allow. One is how malnutrition is affecting the malaria endemic pockets, especially in Northeast India.
Okay, malnutrition is malnutrition creates a complex with many of the infectious diseases, and malaria is also not a surprise. It's a vicious cycle. We don't understand malnutrition. Of course, malnutrition will decrease the immunity, making a person, especially a child, susceptible to malaria frequently. And all of us understand it's not sterilizing immunity what one gets with repeated malaria infections, but partial immunity. If you see areas with high transmission, people attain immunity and the symptomatic malaria doesn't happen. It happens at a low level, asymptomatic, low grade. But a person, especially a child with malnutrition, will suffer from clinical malaria repeatedly, and it not only hampers that particular episode, it doesn't create that particular episode, but the overall health of the person gets affected, and especially a child. Stunting, and all these, the child's growth and the milestones are delayed, intellectual potential doesn't get achieved. All this is happening. Yes, malnutrition should be studied in conjunction with malaria. And Northeast, yes, because Northeast comes with its own problems. I remember when I was in nutrition, there is this problem of low milk intake, vitamin D deficiency rampant in the Northeast. And a lot of what things are available in the rest of the mainland are not available in the Northeast. Malnutrition status is particularly poor. Nutrition status of the Northeastern states. Malaria has come down a lot in the Northeast. And by only Northeast, I feel that states like Jharkhand, Odisha, the 10 southern districts, and the tribal areas, they should be studied very closely. And nutrition has a lot of focus of Government of India at the moment. Poshan and all those programs are going on right now to decline the malnutrition rates in India. We fare poorly in Global Hunger Index is no secret. So I think there's a lot of value in studying malaria along with malnutrition and seeing the relationship together. Malnutrition can also have impact on the way person responds to anti-malarial drugs. So are they equally effective in a malnourished person also is a scientific query. A lot of work is needed in that area, totally agreed. And we should be working in that direction. NMR is already working in that direction. I know it personally as well.
So the next question is, one of the recent paper revealed that the increased dose of primaquine is helpful and reduced chance of relapse. What's your view on this?
Yes, this paper is there. Even I went through this paper. I read it, increased dose, but the current recommended dose of 75.75 milligram is there. And the higher dose will entail efficacy trials for sure, one safety trials as well. Higher dose, and that too with unknown incidence of G6PD deficiency in India will be a problem. I mean, yes, we can try that in a control setting, in RCT format, in a tight clinical monitoring, yes. But I think the current dose is effective, and there is a discussion going on in shortening the regime of primaquine from 14 days to 7 days, if that is effective, because the compliance would be better. A higher dose, we need to see it from the safety angle. And because G6PD deficiency testing facilities are not rampantly available in India, how do we ensure higher dose in a person with risk of hemolysis is safe or not? So that will require a lot of work.
Okay. Another is, do you have any updates on primaquine compliance concern?
I think there should be a very systematic study, and that's on my wish list as well. We should do a multicentric large study on understanding the primaquine compliance in real life situation. Currently, it is not directly observed treatment. In some of the states have done this, like in Daman in Odisha. Primaquine is given in directly observed treatment format, where the healthcare worker sees to it that the person is taking the drug in front. But overall, this is not happening in the country. So we don't know. Healthcare worker just goes and gives a treatment, gives a drug, and the person is taking or not taking the drug. We are not aware. But yes, that's a wish list. We should be doing this kind of compliance study. There are a couple of studies where it has been shown that complete 14-day treatment is not done. Somewhere it is stopped at 5 days, 10 days. See, a person will feel better after 3 days. So the moment there is no felt need of the patient to take the drug, especially it's a rural patient, they will not take the drug. Either government should make it totally directly observed. Every drug intake has to be made mandatorily observable, or we shorten the regime, or we do something like tefenaquine for one single dose and all that. But yes, it should be, but see, a scientific thing that, okay, compliance is poor. We will come to know compliance is somewhere moderate to poor. Then what? We understand. It's intuitive. 14 days, if you ask me, I'm unable to take 5-day antibiotic also. I mean, I was suffering from some infection. I could not take cefixime for 5 days. After 3 days, I was feeling happy, but look at my cough, it's back. So that's how it is. It's very difficult to make a patient take drug. But yes, it needs to be systematically studied to at least show the numbers that it's poor, and we need to have dots as a strategy for primaquine intake.
Okay, if you allow, I can take one more question. If
Please,
so,
um,
so there's a question: what basis are you suggesting change to AL in rest of the India, and what is the therapeutic failure of AS plus SP as per cumulative and best evidence in India?
Okay, that's a very good question. So far, disclaimer, there is no therapeutic failure of ASSP. So many therapeutic efficacy studies have been done by ICMR institutes across where the ASSP is being used rest of the country. There is no therapeutic failure so far. But do we need to really wait for the therapeutic failure? That will mean end of the drug. Okay. So there are indications in the mutations, sextuple mutations, and I showed you the list of mutations there. And there are isolated reports from West Bengal, and there are indications from the molecular studies that SP resistance is there. And we must not forget, SP resistance was there in the Northeast when the drug treatment was changed. And in fact, in this malaria review group, the DGHS was raising this question as a clinician, that students and people travel from the Northeast to India, rest of the India for studies, for work, and they are malaria positive. And we should not forget they must have gotten malaria in their northeastern region. Those parasite strains can be resistant. They are bringing ASSP resistant strains to rest of the India. And we are treating them differentially because they are in Delhi or in other parts of the country. They will be getting ASSP, which is not effective because the strains are northeast. So I think there is a lot of value, and it's no harm that entire country gets a similar kind of a drug. It'd be easy for the country to logistically move to AL. And AL is a wonderful drug. No therapeutic failure of AL in the Northeast. Of course, ASSP also no, because artesunate is working. SP is showing failure in the molecular studies. So this is the kind of a preemptive step which we want to take. Because we are so close to elimination, we don't want to lose it just because suddenly ASSP can fail. And then we think of the switch. And for a huge country like India with 720 plus district where malaria is endemic, switching to a new drug will not be easy. It won't be easy logistically. So that's the reason.
Okay, madam, this would be, I promise, would be the last question. The Dr. Ashwini Kumar want to ask. Bhavani, can we give the access to Dr. Ashwini Kumar, please?
Yes, sir.
Yes, sir.
Dr. Ashwini Kumar, yes, please.
Good to see you. Sir, we can't hear you.
Yeah, and can you hear it now?
Yes, sir.
Yes, sir.
Dr. Manju Rahi, congratulations for covering wide spectrum of issues in 40 minutes. It's not easy, as you know. And congratulations for writing a battery of papers, one after another. Most of them are policy papers. And I know you are not well. You have been coughing throughout. And you are very bold in that sense. Congratulations. But my suggestion would be that I think we should also lay emphasis, this is a suggestion, on urban malaria. Urban malaria is a very tough customer, as you know, Stephen's transmitted, and it's very hard to stamp out Stephen's transmitted malaria because it's a domestic breeder, and you know, and very less populations can sustain transmission. It is very well known, and it has multiple breeding sites, you know, in urban areas. And coupled with migration and development that India is going through, the cycle of development, and you know, increase in our the GDP, and that is fueling now development all around major towns and cities, which is only possible through migrants. You know, they come from malarious areas, they live in shanties, and or sometimes better, you know, sheds made by the large builders and all that. But normally in the medium and smaller construction sites, their living conditions are very poor. So we need to also work on urban malaria related issues and migration related issues, which are very important. As you know, in JMM, we raise these issues. So this is my suggestion to you, and congratulations, you've done a wonderful job today. Thank you.
Thank you, sir. And thank you for all the lovely compliments. And this is, yes, a lot of work has gone into those pieces. And so I think you have touched a raw nerve. Urban malaria is definitely a major hurdle. Look at Chennai or Mangalore, Goa. These are hubs of urban malaria. And the sad part is they are not covered under IRS or LLI. They don't have the usual tools. And larviciding, we all understand how patchy it can be, or it will not simply work. So basically, they don't have any tool to protect also themselves. And as you said, those migrant workers are at the lowest rung of the ladder in the society. They are not included in any program. Their name is not registered. The problems are manifold. You are absolutely right. Urban malaria should be given a lot of emphasis. And basically, we say it's a rural disease, blah, blah. We go on with the rural part of it. Urban malaria is a neglected aspect of it. No qualms about it. So that's an important part. I think we should highlight that from research angle as well.
Yeah.
And
Yeah.
yes.
Thank you.
It's a good pointer, sir. Thank you.
Okay. With this, I would thank you, Dr. Rahi, and other participants. Thank you very much. As Dr. Ashwini Kumar said, despite your poor health, you agreed to deliver this talk today. Even we offered to postpone this talk today, but in that way, I agree completely with Dr. Ashwini Kumar. You are very bold to that despite your poor health, you are here with us, and I would say this was a uh, truly this was a concluding lecture of this lecture series, and I would extend my thank you to all the participants, or the leaders, or the directors, ICMR family, and all. We are very grateful, and we are very I'm very delighted to say that we have received lots of encouraging messages, and lots of positive feedback. So with this, we here decided that we will continue another lecture series, and we will announce the speakers and other details of the new lecture series very soon. Thank you, Dr. I. Thank you very much.
Thank you so much. Thank you to the audience.